Live.
Okay. Welcome, Dr. Amita Banerjee.
Thank you. Thank you. I am really
Professor and Head of Community Medicine, D.Y. Patil Medical College, Pune. He is also a prolific writer. He contributes regularly to the National Herald. He writes in scientific journals and also editorial in magazine published by his own institute. So it is a great pleasure for us to have him on this talk. We hope we'll be enriched by his views. And we also have with us Dr. Sthobit Dasgupta, a cancer specialist and also a prolific writer in Bengali literature. We have with us Professor and ex-head of the department, School of Tropical Medicine, Professor Amitabh Nandi. And we have a medical student with us, Souvik Vishwas. He's a third-year student. It's a great pleasure to have him on this talk. And we'll be expecting another doctor. He's the Associate Professor of Physiology, Dr. Shukanti Bhattacharya. I hope he will be joining very soon with us. So Dr. Amita Banerjee, can you start our session?
Okay, I will just give an outline of the today's theme. That today's theme is the third wave and herd immunity. I think that is, am I right? So I will just try to give, because after the first wave, the curve was coming down. By February, it was almost touching the baseline. And then suddenly the second wave oneki fast rise korlo. It rose very fast. And now that definitely that shook up the country. I mean, that panic is persisting, natural, it is natural. And that again, the second wave coming down as fast as it has gone up. So, but still people are thinking again there will be a third wave. And they are just seeing the picture in other countries and they are predicting on those models. But I would like to explain. In fact, we had a very good opportunity to do some first-hand seroprevalence in our, where we have the medical college. Our medical college is located in Pimpri-Chinchwad. It is in Pune district. It is 20 kilometers from Pune, and it is a highly industrial area. It's a twin township, Pimpri and Chinchwad. Lot of industrial and lot of population movements and lot of settlements in slums and tenements. The population is about 27 lakhs. So our medical college Department of Community Medicine was given the task of COVID contact tracing and also to carry out a sero survey. So last year during the first wave, after September, the first wave peaked in September. Then it started coming down. By end of September, it came down and we carried out a sero survey at that time. So what we found was that overall, we took a random sample of 5,000 people. Overall, we found 35% seropositivity. Among all, we took children also above 12 years, above 12 to 18 years and adults up to above 18 years to any age. And so we found 35% seropositivity, but this seropositivity was not homogeneously distributed in the whole township. Some of the areas had 80%, 70% seropositivity, and these were the slums and tenements where the lower people, lower social class people had to work. They got infected, they got perhaps subclinical, and most of the cases were coming from these places. And when we carried out a sero survey after the first wave, the overall seropositivity in the slums were much higher. Some pockets were 60, 70%. And most of the housing colonies, middle class people, societies, some of the places were less 5% seropositivity or 10% seropositivity, at the most 20%. So a large chunk of the people in the first wave were vulnerable, almost 70, 80%. At that time, if you remember, they carried out the third national level, ICMR carried out the third national level seroprevalence study, and the results came in February after the first wave ended, and they found that 21% of the Indian population had encountered the coronavirus. So that left again 70-80% vulnerable. But still, the cases were coming down, and we analyzed also, because when the second wave came, we again identified those areas which are 70-80%. There the cases were not coming from there. This time it was coming from the middle class and the upper middle class, and the whole families were getting affected. So then we went into the depth of it, and we followed up people also. We had identified out of 5,000 samples, we had identified about 1,500 people who were seropositive in the first survey, which we carried out. And in the month of June, first week this year, we asked them, we contacted more than 1,000. We contacted more than 1,000 of these people who are seropositive to see whether they have any reinfection. So we found out of this 1,000 plus, about 1,040 we contacted, only 10 or 11, I think 11 people had a corona-like illness, which was very mild. They did not require hospitalization, they did not require any medication. And so that means at least for 8 months, the infection, immunity from infection, at least for 8 months, they are protected. So keeping that in mind, now why then we also analyzed why this first wave came down without any sharply. So what we found was, interaction with the population, that those who were there was really a social distancing. I mean, the middle class kept themselves very secluded. They could work from home. They were observing all the social distancing, hand washing. So they were protected themselves by this non-pharmacological interventions. And the poor people, the slums and tenements, very crowded, dense, they had developed herd immunity. So these two combined brought down the first wave very rapidly. And then what happened, it gave a sort of sense of complacency that pandemic is over in India. And then there were announcements in the media by political parties and all that we have won the war against the COVID. So that everybody came out and the mixing started suddenly, the middle class. But the 70-80% vulnerable population suddenly got infected. And the sudden rise may be partly attributed to that these lockdowns and social control measures, the social distancing and working from home must have kept them vulnerable. And the other thing, of course, the new variant also may be more transmissible. You know, when there is a mutation, the variants become more transmissible, need not be lethal. So that gave a large number of cases. And since the panic level is much more than the actual virulence. And what happened when the middle class, everybody wanted a hospital bed. Even those we found in our hospital also, 80% of the beds were occupied by almost, asymptomatic or just become RT-PCR positive. So that crowded the hospital. Sometimes the genuine patients might have been deprived. Even we have seen those who did not require oxygen, they were given oxygen because the panic was high in nursing staff, the doctors treating, the panic was so high, they are treating the patients from a distance and giving everyone oxygen. So artificial shortage can be created by this mismanagement. And then now what happens now, since this new variant can be very highly transmissible, they say the second wave may be due to the Delta variant because it originated in India. It was detected much earlier in India, Delta variant, and we can presume the second wave in India was due to the Delta variant, and it is more transmissible, so it must have infected a large number of people. I mean, almost the recent WHO AIMS study indicates that about 70% of Indians might have, and this time it spread to the rural areas also. Field practice area also we saw in the rural villages. This time we had much larger cases. So because of the industrial area, people moving, frequent lockdowns, people going to the villages from the industrial area, carrying the virus, and it spread all over India because of to and fro movement of the labor. Because there was no fixed to keep them at the place of work. So they just out of uncertainty, they crowded the trains and all. And this time it spread to the rural areas also. So therefore, keeping all this in mind, that second wave was almost 4 times larger than the first wave. After the first wave, we found 21% of Indians infected or showing antibodies against the coronavirus. So if the second wave was 3 to 4 times larger and more widespread, 3 to 4 times more widespread than the first wave, so we expect if the first wave get 25% seroprevalence, you add another 60% or 40%, whatever you want to add, the figure will come tentatively that about 70 to 80% of the Indian population might have encountered the coronavirus. In fact, today only I got my report of antibody and I was surprised. I had titer 180 titer of IgG without, I have not taken the vaccine yet because I had a operation, I was on steroids, so I did not take, but today for the second operation, I did I took an antibody and I was surprised to very high and I never had any symptoms. So that way I am also coming in that 80%. I mean, that too, I am leading quite I'm not mixing in crowd and other things. So even I have got infected and recovered and got antibody. So I think a lot of Indians might have got it. So keeping this in mind and from our first-hand experience, at least 8 months the natural infection gives. In fact, the first wave might be due to the earlier variant. Even that has given the protection against the Delta variant from the second wave. We have interviewed our own participants who had taken part in a survey, about 1,000 plus, that only 11 got. So it gives, I mean, even the other coronavirus is giving cross immunity. So why not one variant of coronavirus will give some immunity too? So keeping that in mind, I don't anticipate that there would be a third wave, at least within 8 months. Or even if it is there, it will be even after 8 months. Firstly, I don't expect there will be a third wave within 8 months. And even after 8 months, it occurs after 8 months, there will be some level of herd immunity, which will cushion the impact. So I think this is my, and of course, children, I'm convinced that children will not bear the brunt because this time they are having large number of vacant beds for children and they're not opening the schools. So I am even the Indian Academy of Pediatricians has said there is no evidence that in the so-called third wave, children will be affected. So children will not be affected disproportionately. Third wave will not come very soon. So this is my just proposition. So we can discuss subsequently. Thank you.
Sir, last year, you wrote a very interesting editorial, Why the Dog Did Not Bark. You said that India's slum population is more than 6.5 crore.
Yeah.
They live in overcrowded places, often with limited water supply.
Yeah.
And maintaining social distancing or frequent hand washing is quite impossible in this scenario. Yeah. So you argued that the dog did not bark here. Likewise, the same thing happened in South Asian and African countries, the poorer countries, where these COVID measures, social measures, is not possible to be followed. So our question is, are we chasing the dog still in opposite directions so that it continues to bark?
This is an interesting question. Because first time in medical practice, we are putting the cart before the horse. You are all very senior practitioners, and we were taught that we will order a test. First, we will see the clinical signs symptoms. Then we will order a test. Here, we are going the other direction. A totally asymptomatic person, you just find coronavirus in this and you label that person as a case. So if you find, you see, and then there is a lot of queries on the RT-PCR also, which has not been answered. Like it picks up just a particle also. It may be a dead particle, that person may not be transmissible. So I was just thinking that if it is so widespread in our country, the 60-70% might have encountered the virus after the second wave. So they may be carrying the dead particles also for 2 weeks, 3 weeks, sometimes for 4 weeks. So in that time, if that person gets some other cardiac event or some other, and if the first thing they do is an RT-PCR. And 60-70% may have a coincidental without that coronavirus being the cause of his or her mortality. And it will be labeled as a COVID death. Every day there are 25,000 deaths in India, various causes. So if you take 60% people are infected, out of the 25,000, if you test everyone, you will find even 4,000 cases every day. So I think it is just this cases depends on the intensity of testing, which has never been very rational after certain time. You see, we were taught even in the old 1986, I have got a WHO guidelines. There were very robust guidelines on how to manage epidemics. I have still got the reference. In fact, I have quoted in some of my editorials and writings. The WHO also gave how to manage pandemics and disasters. He says this, when a pandemic is very new in a particular region, then the testing, tracing, and contact tracing is important. After it goes into community transmission, this is waste of resources. You can only do contact tracing and isolation when you are very sure that either you want to prevent it taking roots in the at the very initial stages. In the middle game, it is a waste of resources, or when you are on the urge of eradication. Last stage, when you are very sure that you are going to eradicate, very cases are coming less and less, when you are there on the point of eradication, that time contact tracing and all, you must have seen in other diseases also. We had a malaria country and all that. When we did house to house, when you are trying to eradicate, of course, that did not, even that was not successful. So this case is just now, and also we are knowing that whenever you are traveling from one place to another, when it's a virgin land, when the cases like yellow fever, if there is no yellow fever in India, somebody come from Africa, he requires a yellow fever certificate. But here, the whole country, we are having, from one state to other, you are having RT-PCR and all. It's a waste of resources. I mean, it's not achieving anything. I mean, when the whole country is having more or less similar, so these all inflate the cases. I mean, and even the deaths also can be inflated. As I said, if 25,000 deaths are there and 60% people are having some RT-PCR, some fragment of the virus will be picked up. So this requires a lot of data cleaning actually to know whether your person is dying with corona or due to corona. So this is...
Okay, sir. Sir, the prevalence rate is so high in India. So does it make any sense? I'm referring to mass vaccinations.
Exactly. This is something which I am very much... you see, prevalence of infection is high, not prevalence of cases. That way you can say 25% people are tuberculosis. Tomorrow overnight, if they change the definition, 30% people will be labeled as tuberculosis because we will be carrying the infection but not suffering from the disease. So here, I mean, the whole... and as you said about vaccination, that's a very, very important point. Actually, we are wasting our vaccination at such what cost? You see what, if 50% of Indians, if you can identify those 50% of Indians who are having antibodies, at least they can wait for 6 months. No? As a second, why go for mass vaccination now? You are wasting the resources. You are wasting the resources. And the claim that vaccine gives better protection than natural infection is certainly not very scientific.
Thanks.
So we can exclude this and we will save a lot of resources. We will reach herd immunity faster, vaccine immunity and the natural infection immunity, and we will be stabilizing much faster.
Sir, you have wrote on the transmission dynamics of the epidemic, and we have learned from your writing and the studies of Dr. Sunitra Gupta and her team that with the depletion of susceptibles in the community, the rate of prevalence reduces gradually and ultimately the epidemic is terminated. So in the light of that view, how can we explain the emergence of second wave, third wave, or any number of subsequent waves as predicted by the media?
Yes, that is very correct. That is the dynamics. Because the second wave came down rapidly because susceptibles were exhausted at a very rapid rate. Add to it the previous susceptible. I mean, previous people who got, like particularly the working class, the people working with their hands, the laborers, the slum dwellers, the tenement dwellers, they're 30%, 25 to 30%, particularly in highly congested area, were already having immunity. Add to that, the second wave hit the middle class, so and the rural areas. So unfortunately, it was a very sudden event, so there were casualties because of the overwhelming of the hospital services. not due to the virulence. In fact, in Maharashtra, very interestingly, in the first wave, the case fatality rate, those who were admitted cases or those who were detected cases, the case fatality rate was 3% in the first wave. In the second wave, it was 1.3%, almost one third. So that means the variant, as the survival of, from the evolutionary theory, the variants, they try to adjust to the host. So the variants which are very virulent, I mean, there is no biological rationality for saying the variant will be more virulent, because more virulent will not, it will kill the host and it will not transmit further, or it will cause symptoms, and people know that you have got symptoms, you isolate yourself. Now everyone has got that message. So any strain which is more virulent, any variant which is more virulent, it will give symptoms, that person will isolate. So it will not survive. So therefore I agree that Delta or Delta plus will be highly transmissible. Now they are saying even if a person goes from just crosses you, he will get that. That is okay. And he is also not having symptom. He will not also have any symptom. And in fact, he will get faster population immunity. So it is, I mean, this is, I would say, one has to think through. If a person is spreading without symptoms, that variant, you also will have, it may be definitely, as you said, the case bulk will, if you do keep on doing RT-PCR, you will keep on increasing the cases. But the death should be the bottom line. We should have granular data on death. The death does not convey anything, because in Italy and in Europe, the average of people dying is 80 years, 90 years. So that is different from a death in a young person. So if you give the deaths, you should tell also how many people 30 years old died without comorbidity, or how many young people died. That will give the virulence. Not everybody dies. So old people, incidentally, in our time also, since we were in medical school, the Souvik will tell that we were taught that any old person or any invalid person bedridden, you have to keep changing the posture, otherwise he or she will get some viral pneumonia or something. That was the usual end stage. It's a viral pneumonia. Everybody gets influenza, or even they have found that even a common cold virus can kill a person who is invalid and bedridden and who has got, he is not moving around. So it just this time it happens to be coronavirus. So I mean, so if you see who are dying, that is more important than just the number of deaths.
Sir, have we reached endemic equilibrium stage, or we are still far away from it?
I think we should reach by another couple of weeks. But you see, one thing is there that some states will reach earlier, because being a large country, it is the states may be in different levels of the stages of the pandemic. So that way it may take time to wait, but we will reach equilibrium. Even if 60% of our people, I mean, if they should do the ICMR, if it does a very rapid sero survey now countrywide, okay, we will have a very good prediction model.
Okay, sir. I would ask Professor Amitava Nandi to say a few words. But sir, do you have any questions to Professor Amitava Banerjee? Please, sir.
Well, thank you, Gautam. And thank you, Dr. Banerjee, for your nice presentation about your work.
Thank you, sir. Thank you, sir.
Good work. In contrast to what I have done in my past life, I mean, not past life, I mean, past academic career. Right now, I am more involved in case of, I mean, in clinical side, clinical aspect of infectious diseases. And although I am very much interested in epidemiological aspect and several other aspects like immune response, the mechanism of protective immunity, the pathogenetic mechanism, how the disease is produced. Now, what we have observed, now before I go to my observation, I have from your study material which you have presented, it's just for my own knowledge, what was the gap between the first survey and second survey? I mean, the sero survey which you conducted. About 15, initially 1,500 people. So it is presumed that you worked with a cohort.
Yeah, exactly. Actually, we carried only one survey. That is the cross-sectional survey to at the end of September or first week of October, we did a survey to find out how many people have got IgG antibodies. And we identified about 5,000. We took a sample of 5,000. Out of that, about 1,500 were found to be IgG positive. And we just interviewed this 1,500 after 8 months. So it was sort of a cohort, you can say, followed them up. It was one survey, cross-sectional plus a cohort. So out of that 1,000 plus whom we could identify, who could locate, about 10 or 11 got reinfection.
Well, that means almost it's a very good sample size. Around 66%. Yes. You could recover from the cohort of 1,500.
And we are still trying to contact the other 500. This is as on today, every day our residents are trying to contact them. As on today, it's an ongoing thing. As on today, we have contacted about 1,000 plus. So we may be able to contact the other people also.
Similarly, in my experience, what we got the infection last year, say from April, May onwards in Kolkata. Now in Calcutta, then all the patients which we treated either in our clinics or under indoor hospitalized patients, some of them, very few of them got reinfected. Of course, we do not know. It is yet to be established whether the second infection is a reinfection or something else like a recrudescence in case of a Plasmodium falciparum malaria. We do not know, but because it happens with many of the microbes. So in case of COVID, most of the questions still are unanswered. So in this case, a recurrence of, rather I should say recurrence of the disease is very, very low, very, very low, indicating a kind of a protection. Of course, this is a very vague observation. This is a very unscientific way of assessing things, because we did not follow each individual patient with indicators of immunity, which still we do not know whether the antibodies are protective or whether there is some other mechanism, particularly the CMI, which is responsible for the protective immunity. We do not know. But what we observed that, yes, I agree with you that the longest period, because I got few of my patients where the disease recurred, it was around 9 months, 10 months plus, above 9 to 10 months.
Yeah.
Presuming, perhaps we can presume at this point that once you get the infection, you may have a kind of a immunity which will protect you from a second infection at least for 8 to 9 months. So in that way, and you very rightly say that infection immunity and vaccine-induced immunity, they are two different things. And obviously, infection immunity is presumed to be much stronger and better than vaccine-induced immunity. So there lies a question everyone is asking, sir, how long the vaccine immunity will last? This is a question which just we are simply we are unable to answer, because these are the questions are supposed to be answered by the house who conducted the studies. I presume that they might have definitely conducted all the preliminary studies regarding answering all these questions. About the hospital occupation, you also stated about the RT-PCR. We know that RT-PCR sensitivity is very poor, and it doesn't discriminate between a replicable virus and a non-replicable virus particle, it's also true. But in contrast to what you observed in your state, in Calcutta, perhaps no one is allowed to go for RT-PCR without any symptom. So that excludes the asymptomatic picking up asymptomatic patients or asymptomatic cases by RT-PCR. Now, this is because all the patients need to carry a doctor's prescription and advice for RT-PCR. So by that, and I know other participants here in this meeting would perhaps agree that unless a person is symptomatic, he is not sent for RT-PCR. So here in Calcutta, we really hardly pick up any asymptomatic subjects, you know. Yeah. So whatever figure we get in West Bengal, in Calcutta, they're all symptomatic, and that represents the cases, not really asymptomatic individuals. Well, in terms of the clinical experience and extrapolating certain aspect of the COVID disease and other things, you know, as regard death is concerned, we are in a kind of a, we are confused why some of the patients, they really die. Now we have really sometime many people, we ask a question, even if there are comorbidities. Now comorbidities may be there, but as such, without COVID, the patient would not have died. That definitely that added up, hastened the pathological process, but there was a great deal of controversy in declaring and giving a death certificate as a cause of death, you know. In Bengal, I know. Other states, I do not know. But here there was a great deal of controversy, right from the period of dengue. Even in dengue, there was a great deal of confusion what could be the cause of death. Now, there was a great deal of discussion among many physicians and the administrative part of the government, and it's still unresolved. But what we feel that the disease, the infection, whether it is dengue or COVID, whatever it is, in presence of comorbidities or in absence of comorbidities, there is a basic pathological process goes on. And this pathological process picks up in terms of speed of damage in those persons who are having other illnesses. That is true. So in this way, all individual deaths can be attributed to the particular infecting agent. In this case, it is COVID-19 or SARS-CoV-2 virus. Now, definitely that doesn't really, as you have very rightly said, that doesn't really give us an idea about the true virulence of the organism in comparison to a normal young adult individual, where the person may die without any comorbidity, indicating a much more virulent virus than things. But in our clinical practice and clinical observation, we hardly got any kind of a correlation between comorbidities and other young individuals. What I mean to say, that the patients behaved in a very funny way, you know. Many patients and majority of the deaths were so sudden and so unanswered, it remained unanswered why the patient progressing well towards a cure suddenly developed complications. Now we have hardly any kind of a laboratory investigating system to go into deep into the investigation about the cause of death and the pathological process. These are the areas, you know, I feel that these are the areas where we need to answer all these questions before settling the issues of virulence of the virus. Now, as far as second wave is concerned, now it was, as you have also rightly said, second wave was much, much bigger than the first one. and more people, particularly more young people, got infected than the first wave. So also the death, even without comorbidities. If we compare age group comparison between the two waves, in the second wave, there was definitely more young people got infected and more death among the younger age group than the first wave. If that is true, then perhaps we may attribute, and if this is an this is a issue to attribute this kind of deaths to the virulence of the virus, then definitely perhaps with circumstantial evidence and clinically, we can attribute the particular the genotype of the virus which was responsible for the second wave as more virulent than the first one. So this is how we clinically try to establish which one is more virulent and which one is not, So the other aspect was, patients hospitalization, need for hospitalization, and the progress towards the death. One thing is very certain, and my colleagues here as participants perhaps will agree, that here in Kolkata or West Bengal, what we have seen, that more the delay in hospitalization, more negligence, even if from the patients or his family members, more is the chance for a fatal outcome. And what we have seen, there is a clear demarcation between two phases in terms of number of days when the patient remained untreated properly. As a matter of fact, from the very beginning, I personally and in my group, we did not use any of these so-called protocol medicines like ivermectin, vitamin C, zinc, and this thing. We never used none of these drugs, 9 or 10 drugs, even HCQS, and none of these drugs from the beginning. And ultimately, now I say that these are useless. Now, maybe, as you said, that the death might be attributed to the lower virulence and the survival rate was much better. As you said, it was 1.3 in contrast to 3% between second and the first wave. This was perhaps, I can add to this, my presumption is perhaps the doctors are more well equipped with their knowledge, clinical knowledge, and the way how they are handling the cases. We are much more conscious, much more knowledgeable than the first wave, how to manage the patients, even the oxygen requirement, what are the drugs and what time, particularly use of steroid, at what time the steroids is to be used, how to stop the cytokine storm and multi-organ involvement, all these. So my feeling is that the better treatment facilities, not in terms of say, equipment and other things, facilities means the knowledge among the medical practitioners, perhaps is one of the very important reasons to bring down the mortality rate from 3 to 1.3 in the second wave. So these are my observations, and there are, of course, there are other things. I am very skeptical about as I fully agree with you. And I always say that in epidemiological point of view, when the transmission is at its peak, it is not really very wise to go for a mass vaccination. Now, every day in my clinic, I am getting patients who got vaccinated and after a week or 3 or 4 weeks, got the attack of COVID, clinical attack of COVID, which was proved by RT-PCR. Now, where from he got the infection? Now, people try to attribute the low standard of the vaccine or inefficacy of the vaccine. Well, I'm not going to agree with that, because there would be a possibility. Because if we go to the people making a queue in Calcutta city, it's overcrowded. We say about making a distance, maintaining a distance, but if you go to the vaccination center, you will see just the reverse. And I'm not surprised to say that many of such patients who got COVID after the either the first dose or second dose of the vaccine got really the infection from the crowd. And this is the danger of starting a kind of a, what should I say, this mass vaccination when the transmission rate is very high. Because I apprehend that even among the crowd, there would be many persons, many individuals who could be carrying the virus as subclinical carriers or asymptomatic carriers from whom the other people would be getting the infection. So this is a possibility.
Yes.
And I am not in favor of going for a mass vaccination at this stage. Let the incidence, let the transmission come down a little bit, and then you can start maintaining a kind of a real vaccination center, ideal vaccination centers. I have seen in one of the in the social media a picture of a ideal vaccination center. It was wonderful. It's a covered place, not temporarily covered space, with having chairs rightly. Each chair is having a distance, desirable distance from each other. Every chair would be carrying a bottle of sanitizer and blah, blah, blah. So that is an ideal situation. People would be asked to get in, and they will be going out by another door so that they don't go back to the the crowd again. So that is a kind of an ideal situation, but we don't see here this kind of ideal vaccination center situation. And this is prompting me to think that perhaps that was not very wise decision to start this kind of a vaccination. Maybe the vaccination, of course, we have been observing that people who got the second dose, even after 26 days, 35 days of the second dose, when it is supposed that the person would be developing the right type of protective immunity, got the infection, and that infection became very, very severe to put the patient under ICU, and with 85% of the lung damaged. So this kind of severity of illnesses, and even in Calcutta, doctors have died after vaccination of COVID, of severe COVID. So even at this point also, I disagree with whatever is said, that the vaccination is a kind of a procedure which can reduce the mortality rate or severity. I think that these are the areas. I'm not attached to any institute now, academic institute now. As you are there, you can ask the clinical counterpart of yours to go for this kind of a investigation into this matter to find out whether really this vaccination which are given now would be able to cut down the severity as well as the death rate in those individuals who are vaccinated. Now, the other issues in case of vaccination is it's a very variable kind of a booster dosing, the second dose. Sometimes they say 28 days, sometimes 50 days, sometimes 84 days. That indicates that they are not yet settled with the answer that what is the right time for the booster dose to be given. Now, I don't know how they have decided. They are deciding the time frame, the time gap when the individual would need a second dose. And I don't know whether, do you have any idea whether the pharmaceutical houses, they are having a kind of a post-marketing investigation or post-marketing research about the efficacy by monitoring each individual who are vaccinated and seeing at what time they develop a kind of immunity. But before that, they will have to settle the issue. What is the right mechanism of immunity, protective immunity? Because you see, there was a great deal of confusion whether the antibodies are really protective or not. Because as we have seen, people who die, they have plenty of antibodies. And I always try to equate the situation with Kala-Azar. In case of Kala-Azar leishmaniasis, the disease Kala-Azar is caused by a situation where the antibodies are available in plenty, but they are absolutely useless in protecting the disease. It is the CMI which is responsible for bringing the cure. And that is responsible again to give a lifelong immunity. So in this case also, in similar to Kala-Azar, in severe cases, in cases who die, the antibody level, anti-COVID antibody level is very high. And recently, in a very small pilot study, one of my junior fellow, he tried anti-HIV viral drugs, antiviral drugs which are used in case of HIV, tenofovir. And I was surprised. In those cases, after cure, the antibody level went up to more than 5,000, 6,000 level. It's tremendously high, unbelievable. Because we say high antibody, even up to more than 150 is very high, we consider that. But 5,000, 4,000, 6,000, it's really unbelievable. Now, that is again another question, whether the presence of antibody is responsible for suppressing the development of protective immunity or not. And in contrast, Dr. Banerjee, in case of subclinical or asymptomatic carrier, I do not know. Definitely, you must be having the case by case report of the antibody. The titer of the antibody which you have got in your studies. Now, in case of, I would like to ask you a question. Among those 1,500 positive individuals, how many were symptomatic and how many were asymptomatic? And all those symptomatic and asymptomatic, whether there was a difference, a statistically valid difference between these two groups as far as the antibody level is concerned. Now, that will give some idea about the nature of the antibody, whether they are really protective or not.
What we could make out is this is actually antibody level, whatever the level, it is only a marker that that person has experienced COVID infection. It, as you rightly said, it did not correlate with the severity or the symptoms. So as you said, it is just a marker that the virus has encountered the virus. And as you said, it may be the T-cell immunity and other things, which may be the actual protective, the long-term memory cells and other things, because antibody also waned. It depends on what time you are taking the sample. If he has recovered after 8 weeks, the antibody may be coming down. So those are the other factors that, because being a cross-sectional study, we don't know at what time of the illness we have his sample we have taken.
Absolutely right.
That was the limitation. And of course, as you said about the post-vaccine, of the manufacturers are not doing such studies. In fact, I just read one of the guidelines from ICMR that people vaccinated should not get the antibody tested, because somebody had gone to court also, I think, that my antibody is not there. So now they have issued a guideline and nobody will test the antibody. So there's a lot of opacity that way. But we are doing a study.
Dr. Banerjee, why they do it? That means this means that antibodies are not protective.
Yeah, that may be one thing. But we are doing, as you rightly said, we are doing studies on neutralizing antibodies in our college. In fact, most of our faculty had taken the 2 doses. In fact, the professor of medicine emeritus, he had taken 2 doses and he did not have any neutralizing antibodies. So we are getting this type of paradoxical findings also. And we are following.
Dr. Banerjee, in your institution or in your area, can you give us a idea about the breakthrough infection in vaccine?
We are doing those studies, and I think a subsequent meeting after a month or after 2 months we can have, and we can share the notes. We have started some studies on this after vaccination. Our department only has started the study. We have just put the proposal. and how the post-vaccination breakthrough infections and all those, and the severity of infections. In fact, I was reading in the Lancet paper, even when they did the trial, they have not studied the severity and hospitalization. They just see the conversion rate. So they are even that is, I mean, incomplete. We don't have the data actually.
Dr.
So
Banerjee, Dr. Banerjee, would you mind if I request you to go for a collaborative study between your institution and our group here?
Okay, I will just discuss. I will see. Definitely that would be, I will just explore.
Right. I would be too happy to go for a collaborative study. And just give you an idea, we have developed a questionnaire. Maybe I would be, if you wish, I can send a copy to you. About vaccination, different aspects of vaccination. All the issues we discussed so far would be incorporated into this questionnaire format to get answers, and it will be my idea is that it should be done through not only through clinicians from their clinics, but also different volunteers in the NGOs and other common people, so that we get some idea about what really happens, what is the efficacy of the vaccine, what really happens after the vaccination. These are the questions which are not really answered by the manufacturing unit.
They are not very clear on that, because perhaps they themselves do not know. And regarding the breakthrough infections, we all have experience of breakthrough experience, say in measles and chickenpox. But it is after 2 years, 3 years, 5 years. We don't have breakthrough infection within 2 months, 3 months. So that is one reason which I have my concerns, that unless we are very sure of the efficacy of the vaccine, we should not invest in mass immunization. I mean, it will be waste of resources, and we find the vaccine is not giving much protection. I mean, and when you are vaccinating young people, you will always get good result, because young people outcome is very, they won't be able to actually evaluate the vaccine. Elderly, and it's a paradox.
I fully agree.
Most of the vaccines are not giving good immune response, because with age immunity, and in the young, they don't require the immune response because they have the immunity. So it is a catch-22 situation.
Paradoxically, even the mode of action of the vaccine is not very clearly said. The mechanism of the protective immunity, if at all it is developed by the vaccine candidate, we do not know.
So there is a lot of gray areas. I mean, once we have so much uncertainty, we should start vaccination in small groups, vulnerable, and study it very well. Once we study it well, then we expand it. I mean, that should be the logical thing. Now we are giving everyone mask. We don't know what's happening. I mean, it's something, and I don't know. Of course, some people have expressed that when a pandemic and less mass scale, it might give rise to mutation also. I am not a virologist, so I wouldn't know that. But these are some of the concerns. And I mean, unless you test it on a small thing, and then you give it when you are, I mean, this is something, it's an opinion, of course, but it has become that the people are also thinking that it is it is something which panacea, that it will eliminate. And now the way they are going for mass vaccination, they are going on an eradication mode. It's too early to go for eradication when a disease, such a large number of asymptomatics and all this. So I mean,
it is a very interesting, enlightening and engaging discussion between two stalwarts of their own field.
I am not a stalwart. I mean, I am nowhere. I visited School of Tropical Medicine in 1994. I was in the armed forces. I was posted in Panagar. So I was looking for a placement on study leave. I got study leave. So I visited School of Tropical Medicine. I think that time director was Dr. Chakravarti, Ekka Chakravarti. I don't know if I am right.
Manish Chakravarti.
Manish Chakravarti. Sorry, sir. Manish Chakravarti.
I was there in tropical school at that time. I retired in 2008.
I had gone to All India Institute of Hygiene Public Health. Dr. A.K. Chakravarti was the director. He was retiring that day. Then Manish Chakravarti was there at the School of Tropical Medicine. I was just a young major that time. And I was giving the reference of Dr. Manish Chakravarti by Dr. Colonel P.K. Datta. He was a public health specialist in the armed forces. You must be knowing him. So I know.
Yeah.
আমি এখন একটু ডক্টর স্থবির দাশগুপ্তকে অনুরোধ করব।
No, I was thinking about the same thing. As you know, Professor Banerjee, Professor John Ioannidis has enlightened us that the infection fatality rate overall, it was 0.2 during the first wave, and it came down to 0.15 now. But the infection fatality rate below the age of 70 is only 0.05.
Yeah.
And on the face of it, we are arguing for, I mean, the establishment is arguing for mass vaccination. Mane, is it not ridiculous to some extent?
Definitely. I mean, in fact, all infection fatality rate is still on the, we calculated from our last zero survey, it was coming to 0.17. It may, I mean, my idea is that we have got a little disadvantage. Like in the Western countries, 70 years, below 70 years, everybody has got a very low infection fatality rate. In our country, there's a burden of hidden diabetes and hidden, hypertension. Particularly, we get this 2 decades earlier than the Caucasians because of our body fat and other syndrome X and other things. So we have got that. And we have done a study in our field practice area in the rural as well as urban area. We found 9 to 10% diabetics, both in rural and urban, and 35 to 45 middle-aged diabetes, 50% were not aware of the diabetes status. So COVID must be affecting them, and that's why we are getting this so high mucormycosis and black fungus and all that, because the hidden diabetes.
True.
So actually,
yes. Very true.
Attacking the COVID problem should not be just giving vaccines for COVID, because diabetes also causes other complications. If we have a good public health services where we have good treatment for diabetes, good treatment for hypertension, and good control of obesity, because in the second wave, what happened, large number of middle-aged, middle class, upper affluent people got affected. And most of the affluent people are having the body mass index, which are almost like the European countries. So they are required more oxygen, they were required more complication, they were requiring for ICU and other things, because it was the affluent class who are, and India is such a large country. We have got Africa inside India, we have got America inside India, we have got India inside India. So first wave affected India, Bharat. Second wave affected the modern Indian, who is more American than Indian in his diet or her diet or in a physical activity. And that's why this was the chaos and panic. I mean, such a large country, we have got everything in India. We can have a lot of this. And as you said, infection fatality rate, you calculate it anyway, it is not more than 1 in any case. Case fatality is about 1.3 this time in Maharashtra. And infection fatality rate, as per the latest survey, like if you have got 60-70 crore people infected, as per the, and if you have got a 2-3 crore, death is just 3 lakh. I had calculated the infection fatality rate in India comes to 0.08. Western country, it is 0.3 or 0.27, but Indian, because of a younger population, it is 0.08.
0.08 only.
Yeah.
I think Dr. Sukhanti Bhattacharya has certain questions.
Yes, he has some questions.
Would you please, Sukhanti? Sukhanti, we are waiting for you.
Gautam, Dr. Sukhanti Bhattacharya has already posted his questions in chat box.
Yes. He was asking some questions about the vaccines and their abilities to produce neutralizing antibodies. Can we be enlightened by our experts on this issue?
Vaccine and neutralizing antibodies.
And this ability to produce neutralizing antibodies.
This study is going on in our institution. This study is going on in our institution. So we'll just, once we get the results, probably we can discuss it in the next meeting. So neutralizing antibodies, as I said, the one professor of medicine after 2 doses also did not have neutralizing antibodies. So a lot of gray areas are there. And you may be aware of the Professor K.K. Agarwal. He, after 2 doses also, he succumbed to.
Yes.
So, I mean, there's a lot of unanswered questions. And Even about the other, I am also another concern for mass vaccination, particularly going to rural areas and door-to-door vaccination, is that we will not be able to monitor the side effects or adverse effects also. This adverse effects reporting is also not very good in our country. So I know anecdotal people who have died within 3 days, 4 days, which are not true. And as per the ICMR, only 1 death has been also. But I myself know of 3, 4 deaths, which...
I agree with you, Dr. Banerjee. I have in my record so many deaths after vaccination, but they are not recorded by the government.
This is unfortunate, actually. This is exploitation of a poor country.
Yeah.
Particularly if you go for rural area, and I know of one of my colleagues, he lost his daughter who was just 25 years old after vaccine, blood clots and other things. So when just recently the report came, there is only 1 death in research. So I have myself, in fact, one of the panel I was having last month, somebody asked me this question, his school teacher, he asked me, I lost my colleague after vaccination, after he had no comorbidity. I said, yes, it is reported and other things. So most of the things are not, I mean, in a country like we should first have our system in place. Then we should go for mass. I mean,
absolutely. You are absolutely right.
No, Dr. Shukanti Bhattacharya. Yes, sir. Go on, please.
Shukanti,
Professor Nandi.
One very
recent. Are you there, Shukanti?
Dr. Shukanti Bhattacharya. Have you any more question?
Mucormycosis. I think he has got a question on mucormycosis, which I said we have got a lot of hidden diabetes. I have ourselves, we have found out in a study of diabetes survey, we found 50% of young people, particularly young diabetics, they are not aware of the diabetic status because initial stage is asymptomatic. So this mucormycosis, and I was just speaking to the clinician last week in my college. I asked them how many are having diabetes. He says 99% of mucormycosis cases are having diabetes. So diabetes, uncontrolled diabetes, it being a diabetes capital of the world. So, I mean, that's why we cannot tackle public.
Sir, actually, there is no change in the cohort between the first wave and second wave in regard to the diabetes, in regard to the iron load, in regard to the deferoxamine therapy among the Indians. But during the first wave, there is no such hype over the black fungus, and which is there now. What might be the reason behind?
They also suspect that it may be the immune compromise due to the virus. That is one. And of course, this time number of cases were 4 times more. And middle-aged people were affected more. So those who are likely to have more diabetes, then the first wave, the lower classes were affected, who may be having less. So these are, of course, speculations. And
Dr. Banerjee, I would like to add one or two things here. Apart from diabetes, the mucormycosis, one of the very important reason for mucormycosis is steroid therapy.
Steroid, people, exactly, you're right. Steroid, in fact, people were self-medicating themselves on steroids because we gave so much publicity to steroids that the lay person was self-medicating steroids. So that is also one important, very rightly said.
The second thing is, in one of my studies in the hospital here, I have demonstrated a kind of an immune response almost similar to HIV/AIDS.
Yeah.
Where I have demonstrated that there is a gross depletion of the CD4 plus cells.
Yeah, exactly. Yes, the clinician was telling me this also. In fact, they have found the HIV part in the virus also. I mean, there is a component of HIV virus in the coronavirus. I mean, whatever the lab manipulation or whatever, there are certain concerns. And therefore, some of the antivirals against HIV also worked in the initial stages.
That is very interesting, Professor Banerjee. That brings us to the crux of the matter, that whether this virus is a natural one or an engineered one.
That is, and
you know, one thing more.
And we all know who was working. And we all know who was working on HIV virus. I won't name him, but we all know who was working on HIV virus.
Professor Nandi, one thing is that almost in every viral diseases, the lymphocyte counts falls rapidly, and so the CD4 also. In any viral infection, be that picorna, seasonal corona, be that RSV, in any viral infection, it is a common feature. It is nothing special to the COVID-2.
Now, see, what I was trying to refer is a similar situation of coexisting other diseases in after the COVID. I mean, during the post-COVID period, our patients suffered from other diseases as opportunistic infections. In those cases, we have demonstrated a gross depletion of the CD4 plus cells, which is not really encountered in any kind of viral diseases other than HIV, leading to AIDS situation.
This was pointed out to
me that might be due to rampant use of so many antivirals.
Well, I cannot ignore this. I cannot say that this might not be the reason, because I personally objected to use of this remdesivir and other antivirals with this simple plea that these are almost all the antiviral drugs. They lead to a kind of a cellular depletion, and who knows that perhaps might target a very specific lineage of the lymphocytes and other cells. We do not know. That is yet to be understood, and studies yet to be done.
Okay. Professor Banerjee, in one of your articles, you have said, the article was Second Thoughts on Mass Vaccination. It was published in National Herald. You have said, vaccine is a strong and powerful weapon against the novel coronavirus, a marvel of modern precision and genomic technology. Now, our question is, from the trials that have been conducted so far, is it crystal clear that the present vaccines which are being given is a strong and powerful weapon?
We have to say that. Politically correct. Otherwise, they will not allow you a YouTube. They will censor a YouTube if you don't praise the vaccine.
We need some form of camouflage.
That is and therefore I said, because a strong weapon, a nuclear weapon was also very strong.
Yes.
My idea was that if you don't use it properly, it can cause more harm than good.
Yes, sir. Yes, sir. Yes, sir.
Hydrogen bomb is very strong.
In one of my earlier panel, I said that only. In fact, the
sir, nuclear weapons can be weapons of mass destruction also.
That's why I said you have to be very careful. Any strong, that's what I quoted from Sun Tzu also, that those who do not know how to use a strong weapon properly cannot use it. Who do not know the limitations of a strong weapon cannot use it properly also. So until you know a limitation of a strong weapon, you do not know the advantage of a strong weapon. That was told by the Chinese philosopher and warrior Sun Tzu.
Sun Tzu, yes.
With a Chinese virus, so we can take the lessons from a Chinese philosopher. That he said a person who doesn't know the limitations of a strong weapon cannot know the uses of a strong weapon.
Right, sir.
So we should know this limitation. That's why I have my concern that strong weapons should be used very judiciously, very, very judiciously.
Sir, you have said that there is limited evidence that current vaccine can interrupt transmission.
Yes, that they also claim. I mean, I have never seen a vaccine after which you have to keep on wearing masks, you have to keep social distancing, keep washing hands. How will you know what is working? I mean, that means the manufacturers themselves are not very confident that the vaccine.
Yes, sir. Yes, sir.
Gautam,
yes.
One of the advice which is coming from the manufacturing company, it says that they cannot guarantee that there will not be any infection or transmission after the vaccination.
Even so the chief scientist of WHO said that they are not sure whether it prevents someone from getting infection or from passing it on to others.
They say
it is on record.
But
some quarters, it is claimed that these vaccines reduce the severity of the disease, reduce hospitalization, and prevents deaths.
It reminds me of the BCG vaccine also. They claim for the BCG vaccine also.
Yes. I agree with Dr. Banerjee.
And it's very difficult to know.
But people are skeptical about it. As Dr. Nandi has said, there are numerous instances of people succumbing to the infections even after getting 2 shots. So what is the point? What is the point of taking vaccines then? What are the benefits that we can expect from getting these vaccines?
Exactly.
In spite of so many uncertainties and skepticism.
You have to calculate the risk benefit. If a person has got a very, and we know by now the high risk group, that people with comorbidity, you can take a risk with the vaccine because you have got a risk of dying without the vaccine. But in as you go to the younger age groups, the risk benefit doesn't work out. You see, they have got no risk of getting the disease or dying from the disease. And the vaccine may have a remote risk or may have no benefit. So unless you have good data, you cannot work out the risk benefit also. I mean, why doesn't we have data on the mortality age wise? We have it. Indian data should be there. We have it. It is 0.001 children. Pediatric.
Yes. Yeah. So currently, in which direction the tip of balance between the risk and benefits is going? Is it towards the risk or it is more towards the benefit? What is your assessment?
I mean, it is just going for mass vaccination. Nobody knows what is the risk. Nobody knows what is the benefit. We are going without a compass. And even today only somebody sent me the Devi Setty's statement. He is the advisor to the Karnataka government. That you don't allow anyone to enter aircraft. You don't allow anyone to enter here. If you're not, you are indirectly forcing people to take vaccine, that vaccine part 4. So people are interested in mass vaccination, school, college, everything. I mean, without knowing what is the risk benefit. And if you do it that way, you will never know what is the risk benefit. So there should be some proper data, which is, I mean, these vaccines are still in emergency use authorization. So they require proper evaluation before rolling out on a mass scale. Emergency means who is at emergency of mortality and morbidity. The high risk group are, so it should be for, it should have come with that condition that this is emergency use authorization. You use it only those who are at high risk. But mass vaccination is something which I don't see where is the science in it.
Yes, sir. Sir, you have made strong opinions in favor of reopening schools. Can you please elaborate on us?
Yes, yesterday only I had an interview on reopening schools. We have got some evidence from countries like Sweden. Of course, Sweden is a small country, but throughout the pandemic, they did not close the schools, at least till 17 or 16 years of age. And throughout the pandemic, they had the ICU admission was less than about 1 at ICU admitted in 1 lakh people, 1 lakh children. And they had 15 children who had that Kawasaki type of syndrome and all survived. And last year, during the peak of the pandemic in Europe, they have published studies. There are 2 concerns or 2 or 3 concerns regarding schooling or opening of school. One is the pediatric morbidity mortality. Second is that children will go to school and they will bring the infection back to the elderly in the house. And third is that they will trigger community transmission. So there have been studies on all these 3 aspects in Europe. So firstly, children, they collected data from 7 countries in Europe at the peak of the pandemic last year. And they found out of 45,000 infections, there were only 40 deaths in pediatric age group, 0 to 18 years. And they compared it with other mortality. They found the deaths due to non-COVID causes were much higher in children than COVID causes. In fact, COVID contributed to only 0.3% mortality in the pediatric age group, and the remaining 99.6% were due to other causes. Most of them were due to accidents. More than 1,000 deaths were in accident, or 1,200 deaths were accidents. Then even influenza was 3 times more than the COVID deaths. So influenza in children is more lethal than COVID. Then they also did studies regarding the transmission. This is published in Pediatrics Journal, in the American Pediatrics. So they have done studies among the transmission from children to adults. They did the contact tracing and other things. They found 90% of times the children got the infection from adults, not the other way around. So they found that children do not transmit it to adults. Right. Because firstly, they have a very low viral load, because physiologically also they are protected. They have got a very big thymus, very active thymus gland, which gives the T cell immunity. They don't have much ACE receptors in the lungs, which the virus attaches. Then they have got a high level of melatonin. So physiologically they are protected. They cannot transmit to adults as easily as adults transmit to them. And secondly, because of the height also, they cannot, they cough, it will fall to the ground. The adults are taller. And they themselves also do not suffer. And they also, they have found a very peculiar, unlike influenza. Influenza, the children can act as transmitters to the community. So they have found the influenza outbreaks can be triggered from schools. But in COVID, they found no such evidence. They found that it does not transmit. The COVID is peculiar because, as Professor Nandi was also saying, it is perhaps the T cell which works, and the children have got good T cell immunity. So these are all the directions which it forms that the children do not transmit. Children firstly do not suffer. Children do not transmit to elders. 90% time. I mean, for public health policy, we go for the big picture. There may be occasional cases, but that is one odd case of children may have transmitted. That is not for public policy. Of course, I have a little of caution here that children with comorbidities may be identified and they can be protected. Children with, say, endocrine disorders, or children with congenital heart disease, rheumatic heart disease, or children who have got juvenile diabetes. So they have got studies on the children with comorbidities also. They found that children with comorbidities may have slightly more chance of morbidity and mortality compared to a healthy child, but still children with comorbidities have a less mortality than adults with comorbidity. So keeping everything in context, it can be, and I suggested also in my last discussion on this, I suggested that we can have at least open the playground, let the children play in the open. I mean, open air transmission is not there. Another thing which I found was, in fact, I'm just connecting the dots. About 3, 4, 5 years back, we did a study of vitamin D levels. And we compared adults and young people. We found the young people were 4 times more vitamin D deficient than adults. So that may be one factor which affects the immunity of children. So if they go out and play in the playground, now they are locked up inside, they will get, the immunity will come down, their physical, mental health will be affected adversely. They can have classes in the open, in the playground, in the verandas. They can spread out a little. And they will definitely, the evidence from Sweden, which did not close the schools, are quite encouraging. In fact, they found that school teachers were also not having higher morbidity, mortality compared to earlier years. So they are not transmitting. I mean, that these fears are unfounded.
Right. Sir,
and we should collect our own data. I also say that ICMR, we are doing RT-PCR with children also 0 to 18 years. We should follow them up. We can link up and we can have our own database to reassure the parents and policymakers. If they want to, they can do it easily.
Sir, media is making hype on another topic that they are citing the recommendations of experts that it can also be used in pregnancy. But one of the vaccines clearly said in the fact sheet that the pregnant and breastfeeding women should not take this vaccine. And the other vaccine fact sheet, they say that they have limited data on animal studies. So can you say something on it, the use of it in pregnant and breastfeeding women?
As a general rule, we avoid any drug, any vaccine in a pregnant and lactating until unless we are very sure of the side effect. When the manufacturer themselves are saying they are not very sure, I don't see the rationale, I don't see the,
I think Dr. Bhaskar Chakraborty is having with some questions. Please, Dr. Chakraborty.
No, actually that topic was discussed, but still I have it. that remdesivir, what I have seen in very limited literature, that it has adverse effect as a respiratory failure is one of the adverse effects of remdesivir. So how can then it be included in a protocol which for treating pneumonia and respiratory diseases?
Probably as an antiviral, they are seeing only one aspect, it is an antiviral. They are not seeing that in some cases it is causing the respiratory side effects. So it is, they had now restricted it to clinical judgment. So that is again a very vague thing.
Actually, in my hospital, I cannot give material proof just for the sake that it is a private hospital and I cannot bring out material proof from there. Actually, what I'm seeing there is that a lot of patients, they are mildly diseased, moderately diseased when they are entering the hospital. And when they are coming out either severely diseased or sometimes as dead bodies. It is an observation.
Oh, yes.
So that is why I am very skeptical about the treatment protocol actually.
Yes, what Dr. Chakravarti is saying is just like entering a screening camp for cancer. When you go into a screening camp, you go as a man and you come out as a cancer patient.
These are all repurposed drugs, so we just don't know. They are just shots in the dark, and they have all been withdrawn now.
Yeah.
Okay.
Yes.
Shovik is listening with rapt attention. Shovik, do you have any questions to our teachers?
Yeah.
Sir, actually, I don't think that this vaccine, which efficacy is not has yet been proved and is given to all. In my area also, one death occurred just after vaccination. But after 2 months, there is a news that this is the first death. So this death was not recorded. So I am against mass vaccination, and I think it should be studied for at least a year or so. And the person whom we are giving the vaccine, they should be challenged with the virus. And if we get the proof that this is protecting them and also it is preventing the transmission, then only this mass vaccination program can be started. But everywhere it is now unofficially all the institutions are forcing their students or employees that to take the vaccines. Otherwise, they'll not allow. I myself have has faced such a problem that my college indirectly was forcing me to take the vaccine, though I have not taken yet. So I want to know one thing, that if these institutions are forcing us to take the vaccines, so is there any method to know that it may cause harm to me, like when for any drugs we do skin test or like that? So is there anything that is there any method that we can know that we may have some effects, immediate effects? I mean immediate effects.
You are asking me. Anyway, I'll try to answer. You have answered. You have asked a number of questions.
Professor Banerjee, actually in continuation with Shovik, may I put the question? Please, that this vaccine has been tested for efficacy against the picornavirus, but not the coronavirus too. So how can it assess the efficacy of this against COVID?
As I said, even whatever trials they have just done a surrogate measure, whether there is how the participants are responded in the immune response, the antibody level. They have not done a full trial of, say, efficacy, and even after the efficacy, there is an actual in field conditions, that is the effectiveness. So until unless it is data is collected after it is rolled out, we would really do not know, have these answers, firstly. And secondly, at the trial level, they do relative risk. So once they do the population, you have to see the attributable risk reductions, which get influenced by many other factors, like the incidence, prevalence of the disease in the community, the herd immunity. So everything will get very blurred, actually. It is something like you buy a car, under ideal condition, you will say it will give you 30 km per liter, but when you come to this Sealdah, it will give you just 5 only, because traffic jam. So the vaccines and other drugs also work on that. On the trial conditions, the results are different. And of course, Soumik, your name is Soumik, no?
Souvik, sir.
So you have asked about the challenge trial, that you inject someone and then you give him the virus. So that after Edward Jenner, it has become unethical. Only Edward Jenner could do it. He took that boy and injected the smallpox virus. So no ethical committee will allow that challenge trial. So they have to just give the vaccine and watch the, how it control group and that group. One is given the placebo or some other vaccine and then they see that. So it's a very, indirect way of measuring the efficacy and efficiency. And you see, most of the respiratory vaccines, they start with good and subsequently it comes to 50%. You see H1N1 vaccine efficacy is now 40% or 50%. So they start with a bang, then it gradually comes down. There are mutations.
Is it 40 to 50% or is much less than that?
I am again being diplomatic.
Sir, Souvik has raised a really alarming issue, that the medical college authorities are pressurizing the medical students themselves to get vaccinated. Sir, as a teacher, would you like to comment on this?
I am I have not taken myself, but I got a very high antibody level today. I just got it. So I have not taken, and it is an independent, and I keep telling people also, so that you should not take my example. You have to make your own independent decision. After, you should ask everything. As Souvik said, you should know everything. The small print, you see the manufacturer, what they are saying. And based on that, manufacturers say that it will not, you can question it. You can put that on here, you can question it, where is the authority that, and secondly, I believe these vaccines are still in emergency use authorization. So they are sort of under trial. So under trial without informed consent, legally, nobody can force you, they force you otherwise. And in fact, I don't know, last week only, or I think 3 days ago, there was one Air Force personnel. Yes. He went to court and the court gave a stay order. That he said, I will not take the vaccine, and the court upheld it. So if in the, so it depends, personal, it's a personal call. You have to really, they are indirect pressures. I agree. They are indirect pressures. And after the Devi Sethi, what he gave the statement, the pressure becomes, such people, when they give this type of statement, the political and the administrative authorities also, they make some deterrence, those who do not take it. It's almost coming to something like Sanjay Gandhi sterilization. So yes, I think after that we are having, we are almost, so you see in the long run, this boomerangs. It doesn't work in the long run. So let us hope that good sense prevails. And that's why I am always for going as a targeted, focused, something like Barrington Declaration. In fact, I was saying this, both will, the John Snow and the Barrington, these are two parallel lines, they will meet before infinity. Because when we have limited vaccine, we will go for focused prevention. And but it appears now there every day some new vaccine is coming, and everybody, there is a big market, that way. Already they are, what's happening. With so many vaccines.
Already there are almost 200 types of vaccines.
320 candidate vaccines.
320.
Already, and then if more vaccines come, it will be difficult to know the which vaccine is causing which side effect. Which vaccine is,
yes, sir. It will be a complete mess.
So, Nasbandi ka din aa gaya, sir.
I will again go back to Dr. Sthobit Dasgupta to raise some pertinent questions that probably we are leaving behind before wrapping up.
No. I don't have any more question. I was listening and I was enjoying. I want to be more enlightened by Dr. Amitabh Banerjee and Dr. Amitabh Nandi.
Very kind of you, sir. It's a real honor and privilege. I mean,
Professor Nandi, do you have any more questions to ask?
No.
I have to ask, sir. He is a guru. How he can School of Tropical Medicine. I was very much interested in this. I used to walk in this college street, enter these big institutions, and really feel I had in 91 আমি প্রবাসী বাঙালি আসলে আমার প্রবাসী বাঙালি so armed forces এ ছিলাম তো temporary duty মাঝে মাঝে যেতাম so I used to visit these institutions and really feel I used to see the specimens and all that so really it was like a temple to me.
স্যার শেষ প্রশ্ন আমাদের যে শ্রোতারা আছেন তাদের জন্য আর কি আপনি একটু বলুন যে আপনি on talking about mask mandate you have mentioned that you have said citizens of almost all countries including major democracies have complied with measures which deprive them of their fundamental rights. A major contributor to the pandemic of panic has been draconian measures which has no precedence in the history of public health. Now we are listening about some news on vaccine mandate. Please leave some comment.
Regarding mask or what?
Mask mandate, I think mask.
Yes.
You see, the only way is discussion. The only way is discussion and gradually the fear. Well, there is discussion and the actual seeing the situation on ground, data transparency, and that only will bring about. And once they open the schools, once the life comes back to normal, it's difficult. I mean, it's not, I mean, we can only think of it and exchange ideas, but gradually people, like initially they started censoring a lot of things. But I think I have a feeling that that people have really protested against it, and some of the censorship has been diluted. I mean, that censorship is not as it was earlier, because once they find things are not working, then you see, initially anybody talk of the lab leak theory was censored. Even Fauci went against and admonished the Indian scientist who wrote a paper that this can be from a lab. Then the Fauci had to apologize. So the people are watching all this. So gradually they will, I mean, gradually the foundation will shake. I mean, and it will come from the Western countries where people are more articulate. Here we are a bit compliant, I think. So, but once things change in the Western countries, and you must be aware of the ivermectin meta-analysis, which has really been, and those people have also given evidence and all that. So, I mean, this type of thing, we hope that this information sharing is the only way where you can really, you can attack this type of authoritarianism. You see this, okay, everybody complied, all citizens complied with this. You see, they complied with social distancing, they complied with lockdown. Had it worked, people would have continued, but it has not worked. In spite of all this social distancing and all that, the virus came from China to Chandni Chowk. So that means the people will also realize what's happening. And people, when they find the results, 60, 70, 80% have encountered the virus and nothing happened to them. So what is the use of this social, I mean, gradually or quite fast, actually. It was just the second wave was an interruption. And I also consider the second wave as a outcome of this lockdown and repressive measures. But the middle class took it very seriously. And you see, lockdown and this non-pharmacological interventions cannot prevent transmission of a disease which has got so many asymptomatics. It can only postpone. And we got it with interest, the second wave, because it was postponed and large bulk of the population were left vulnerable. So had we had not such strict measures, this would have, at a low level, it would have settled down. I mean, it would have been staggered over time. So it was postponed and suddenly everyone came out. It overwhelmed the hospital services. And naturally that created panic. And it was a disaster because everything came, all the patients, the caseload. And that type of, anybody who has got, I have seen people, they are normal. Once they do a RT-PCR, they start getting breathlessness. So that psychosomatic element, and particularly in the middle class, and then they go and create chaos in the hospital for beds and oxygen and other things. So it is those, that risk communication to the general public, and the media, of course, daily it wants to exaggerate things. So all this added up to it. So, but with this type of exchanges and people watch the YouTube and other things, in fact, after some time, I think they will realize you don't have too much lockdown because people are seeing too much YouTube and getting educated. So let us let them go out to the market so that they will not come to know what's happening. So that may also, in the long run, the exchange of ideas may allay the panic, should allay the panic.
Now we are going to demand from the government that instead of lockdown, you must completely lift up the lockdown theory, not only partially. It should be complete lift down. Then you have to arrange 24/7 working days for all. For all, because you have to make up the loss. In that way, you can manufacture some other, the working abilities, working avenues, also new working avenues, because otherwise the people cannot live on dole and they cannot go on begging only. So we do not know whether the intellectuals are going to support us, but we are trying to convince them.
Okay, sir.
Any more questions, Gautam?
No, we have almost reached at the conclusion of our conversation. It was a very engaging and enlightening conversation between the experts and many viewers who are watching our program through Facebook. And we can end with a positive note that if we continue our quest for the truth about COVID-19 and the vaccines, the veil of uncertainty and darkness will once be lifted and people will know the truth. Thank you. Thank you.
Thank you.
Good night.
Good night. Thank you. Namaskar.
Thank you. Thank you very much.
Enjoyed.